Welcome to the 2020 Vermont Statewide EMS Protocol Update. This module includes the American CME curriculum for identifying large vessel occlusion strokes with FAST-ED.
Hello, and welcome to American CME's presentation, Identifying Large Vessel Occlusion Strokes, LVOs, with FAST-ED. I'm Dr. Lee Schwam, an American Heart Association and American Stroke Association volunteer, and a neurologist at Massachusetts General Hospital in Boston. Over the last decade, tremendous advancements have been made in the realm of endovascular therapy, or EVT, for the treatment of acute ischemic stroke. When treating certain types of ischemic stroke, EVT involves advancing a catheter within the affected artery to the site of an occlusion. Mechanical thrombectomy with a stent retriever has been established as the standard of care for selected patients suffering from large vessel occlusion stroke. As a result, early recognition of LVO stroke in the pre-hospital setting has become a priority for EMS systems around the world. Consequently, a number of stroke severity scales have emerged. Stroke severity scales are designed to identify LVO stroke patients who may be candidates for mechanical thrombectomy. The Field Assessment Stroke Triage for Emergency Destination, or FAST-ED, stroke severity scale was developed deliberately for EMS providers to predict LVO strokes in the field. This course describes how to apply the steps of FAST-ED and lists additional key priorities associated with best practices in stroke patient assessment and care. By the end of this course, you will be able to describe and define large vessel occlusion strokes, list and describe the steps of FAST-ED, list and describe the 3 key checkpoints for EMS communication with the receiving hospital, and finally, list and describe EMS treatment considerations for acute stroke patients. An LVO stroke affects any of the primary arteries that supply the brain with blood, making it the most severe form of ischemic stroke. These primary cerebral arteries include the internal carotid arteries and the proximal segments of the middle cerebral arteries, as well as the basilar artery. LVOs are surprisingly common. As an EMS provider, it's very likely you have already encountered a patient experiencing an LVO stroke. In at least one study, the incidence of LVO stroke was estimated to be up to 20% of all ischemic strokes. In addition to being common, LVO strokes are associated with a striking increase in the risk of death and severe long-term disability when compared with other strokes. More importantly, a recent study indicated that IV-TPA is frequently ineffective at fully treating LVOs. Achieving reperfusion in that study was a mere 10%.
Hi, I'm Dr. Bay Leslie Marsby, an American Heart Association, American Stroke Association volunteer, and a neurointerventionist at Massachusetts General Hospital in Boston. The majority of large vessel occlusion strokes are caused by an embolus that's traveled from another location in the body and become lodged in one of the primary arteries of the brain. Due to the size of these clots, IV-TPA alone is often ineffective at dissolving them and reopening the occluded blood vessel. For the last 2 decades at least, extensive research has been invested into additional therapies that might address this shortcoming, this conundrum of the largest clots being the least responsive to IV-TPA. One of these therapeutic alternatives, or adjuncts, to IV-TPA is mechanical thrombectomy. Mechanical thrombectomy is an endovascular therapy inside the blood vessels that involves the physical engagement and removal of the clot with an intravascular device. Several randomized clinical trials conducted with mechanical thrombectomy have demonstrated profound benefit to a select group of LVO stroke patients. These trials have established mechanical thrombectomy as the clear standard of care for LVO stroke patients that meet criteria. To understand the implications of these recent discoveries for EMS providers, it's helpful to recall how IV-TPA approval by the FDA in the mid-1990s changed the way that we responded to stroke. Stroke was largely considered untreatable prior to FDA approval of IV-TPA as a stroke medicine in June of 1996. Although it may be hard to believe now, Prior to IV-TPA approval, stroke was treated as a non-emergency condition, primarily managed with long-term rehabilitative therapy. The approval of IV-TPA as a stroke medicine led to the creation of pre-hospital stroke recognition scales, like the Cincinnati Pre-Hospital Stroke Scale in 1997. It also led to the establishment of primary stroke centers in 2004, and in many regions around the US, hospital bypass legislation of non-stroke center hospitals. Similar to IV-TPA, mechanical thrombectomy is changing entirely the way we respond to stroke. The 2018 AHA guidelines for management of acute ischemic stroke recommend mechanical thrombectomy for eligible LVO stroke patients with a treatment window that extends out as far as 24 hours for select patients. The guidelines also recommend early IV-TPA use for all eligible patients in combination with mechanical thrombectomy. And like IV-TPA, studies have shown that the earlier the clot is removed with mechanical thrombectomy, the more likely the LVO stroke patient will experience a good outcome. As a result, an emphasis is now being placed on the early recognition of LVO stroke by EMS with the use of pre-hospital stroke severity scales. In addition, in order to increase patient accessibility to hospitals certified to perform mechanical thrombectomy and to reduce the time to intervention, the Joint Commission established criteria for a new stroke center designation, known as thrombectomy-capable stroke centers, and began certifying them in 2018. The science continues to evolve, and as new evidence becomes available, new recommendations will likely emerge. One thing is clear, however: EMS must continue to evolve in response to these new and incredible stroke discoveries.
In March of 2017, in response to the overwhelming evidence that confirmed the effectiveness of mechanical thrombectomy for selected LVO stroke patients, the AHA presented their Mission Lifeline stroke severity-based triage algorithm for EMS. In this algorithm, the AHA recommends the use of a stroke screening tool to screen patients for signs of stroke when indicated. Then, if signs of stroke are identified, the algorithm recommends the use of a validated stroke severity scale to estimate the severity of stroke and predict the likelihood that an LVO is present. Stroke screening tools like the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen, and the Boston Stroke Scale have been widely used by EMS for nearly 2 decades. Stroke screening tools were designed specifically for use by EMS to detect signs and symptoms of stroke in the field. They're simple to use, they have good sensitivity for detecting the common types of stroke, and these scales were developed to enable EMS to identify patients who may be candidates for IV-TPA in order to allow for triage and early notification of the nearest designated stroke center. In comparison, stroke severity scales like FAST-ED have been designed specifically for EMS to quantify the severity of the stroke and recognize the most reliable indicators that an LVO stroke is present. While stroke screening tools were constructed to simply identify the most common signs of stroke, stroke severity scales are designed to identify candidates who might benefit from mechanical thrombectomy. However, no stroke severity scale is perfect. In fact, far from it. Even the most comprehensive of stroke severity scales are only modestly effective at predicting LVO strokes. With that said, a severity scale's effectiveness at predicting LVOs should be based on a predetermined acceptable false negative and false positive rate. The idea being, a good stroke severity scale will manage to balance the need to identify as many candidates for mechanical thrombectomy as possible, while at the same time assuring the false positive rate, or over-triage rate, doesn't make the scale unreliable. One author suggests a reasonable goal is a false negative rate of less than or equal to 10%, meaning cases you miss, and a false positive rate of 30 to 50%, meaning cases you identify as an LVO that turn out not to be. Now that we have a basic understanding of what a stroke severity scale is designed to do and why, let's take a close look at how to apply the steps of FAST-ED.
FAST-ED is a double acronym, which stands for Field Assessment Stroke Triage for Emergency Destination, as well as Face, Arms, Speech, time, eye deviation, and denial neglect. The double acronym conveys the original intent of the scale, as well as summarizes all of the assessment steps associated with completing the scale. FAST-ED was created to reliably triage patients to the most appropriate stroke center in order to assure timely patient access to definitive care. FAST-ED incorporates both a stroke screening tool and a stroke severity scale into one assessment. This allows for a streamlined assessment of potential stroke patients. FAST-ED assigns a score from 0 to 9. Many EMS agencies that use FAST-ED utilize a checklist to assist with completing the assessment and scoring the deficits. A sample FAST-ED scoring checklist is available to you for download. Click on the additional course information link underneath the video screen to download a PDF version. You may want to pause the video and download our sample FAST-ED scoring checklist to help you understand the steps of completing and scoring FAST-ED more clearly. Anytime a patient presents with an acute onset neurological complaint, assure the patient is screened for stroke. Common stroke signs and symptoms include hemiparesis, which is weakness on one side of the body; hemiplegia, which is paralysis on one side of the body; facial palsy, also known as facial droop; dysarthria, or slurred speech, which is a focal motor deficit making it difficult to articulate speech; dizziness and vertigo; expressive aphasia, which is the loss of the ability to produce written or spoken language; receptive aphasia, which is the loss of the ability to understand written or spoken language; eye deviation, which results in a fixed gaze or difficulty looking to one side; denial neglect, which is the inability to respond to stimulus on one side of the body, usually the left side. Stroke signs and symptoms can be less obvious and also include an altered level of consciousness, sudden severe headache with no known cause, visual disturbances, generalized weakness, motor ataxia, as well as frequent or unexplained falls. If any potential sign or symptom of stroke is identified during the initial patient assessment, screen for stroke by applying the first 3 steps of FAST-ED. These steps comprise the stroke screening portion of FAST-ED. First, assess the face for partial or complete paralysis to one side. Then, assess the patient's arms for drift or an inability to lift one or both arms. And assess for speech changes, including dysarthria or slurred speech; expressive aphasia, which includes testing for the patient's ability to name at least 2 of 3 objects that are easy to identify; and receptive aphasia, which includes testing for the patient's ability to follow a simple command. If these steps sound familiar, they should. They are the steps of the Cincinnati Pre-Hospital Stroke Scale, with a few additional criteria added to the speech assessment. To make the scale easier to learn, FAST-ED was intentionally designed to be analogous to the CPSS, which has been used by most EMS providers for almost 2 decades. If signs and symptoms of stroke are not detected during the stroke screening phase of FAST-ED, EMS providers should consider ending the stroke assessment and continuing to assess and treat the patient based on their condition per local protocols. If signs and symptoms of stroke are detected during the stroke screening phase of FAST-ED, the deficits should be assigned points based on the scoring criteria defined in the scale. In just a moment, I will discuss in detail the scoring criteria of FAST-ED. But first, let's continue with our overview of FAST-ED by briefly discussing the next step: time. When signs and symptoms of a stroke are noted, EMS providers should make a reasonable effort to obtain and document 2 different sets of times. A last known well date and time, which is the date and time the patient was last known to be at their normal baseline, as well as the date and time of sign and symptom discovery, which is the date and time signs and symptoms of a stroke were first discovered. For example, a patient went to bed without stroke signs or symptoms at 10 p.m. the night before. The next morning, family identified stroke signs and symptoms at 6 a.m. when the patient awoke. In this case, their last known well date and time is 10 p.m. the night before, and the stroke sign and symptom discovery date and time is 6 a.m. on the morning the patient woke up. Assure you document both sets of dates and times. Finally, when signs and symptoms of a stroke are detected, the remaining steps of FAST-ED should be completed. These final steps consist of testing for eye deviation to identify a fixed gaze or difficulty looking to one side, and when indicated, testing for denial neglect, which includes anosognosia, more commonly known as denial, is the inability to recognize weakness in their weak arm, and asomatoagnosia, more commonly referred to as neglect, is the inability to recognize or identify with their weak arm. Again, when signs and symptoms of a stroke are noted during the screening phase of FAST-ED, score the severity of the deficits noted. Then, complete and score the remaining steps of FAST-ED. The assessment and scoring criteria for each step of FAST-ED consists of the following. For facial palsy, ask the patient to smile or show their teeth. Evaluate for facial asymmetry and/or a flattening of the nasolabial folds. The nasolabial folds are the folds that run from both sides of the nose to the corners of the mouth. A score of 0 indicates no facial droop or only minor paralysis to one side of the face. Conversely, a score of 1 indicates partial or complete paralysis of one side of the face. For arm weakness, ask the patient to hold both their arms out in front of them, palms up, with their eyes closed for a count of 10. A score of 0 indicates no drift, or both arms slowly move down equally.
Ma'am, I'm going to have you lift both arms up, palms up, close your eyes. Now keep them there for a count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
A score of 1 indicates arm drift, or some effort to lift the affected arm against gravity.
Ma'am, I'm going to have you lift both arms up, palms up, close your eyes. Now keep them there for a count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
A score of 2 indicates no effort against gravity or no movement in one or both arms.
Ma'am, I need you to lift both arms up, palms up, for a count of 10 and close your eyes. 1, 2, can you lift your left arm for me? I need you to lift this up. 3, 4, 5, 6, 7, can you move your left arm up? 8, 9, 10.
When assessing speech, check for dysarthria. Consider asking the patient to repeat a simple phrase. For instance, ask the patient to repeat, "You can't teach an old dog new tricks." The patient should be able to repeat the phrase without slurring. Dysarthria is a positive sign of stroke that is not awarded points on the FAST-ED scale. More on that in a moment. Next, as a part of the speech assessment, check for expressive aphasia by asking the patient to name 3 common, easily identifiable objects. For example, their phone, a pencil, and a remote control. A score of 0 indicates the patient was able to name all or at least 2 of the 3 objects.
Pencil, remote control, phone.
A score of 1 indicates the patient could name none or only 1 of the 3 items correctly, or is unable to speak at all.
Pencil,
Next, check for receptive aphasia by asking the patient to perform a simple task. For example, ask the patient to show you 2 fingers on their unaffected arm. It's important to avoid demonstrating the task, as the test is intended to assess the patient's ability to follow verbal instructions. A score of 0 indicates the patient was able to show you 2 fingers when prompted.
Can you show me 2 fingers on your right hand?
A score of 1 indicates the patient was unable to perform the task.
Ma'am, can you show me 2 fingers on your right hand?
Aphasia is one of 3 cortical signs tested during the FAST-ED assessment. Cortical signs of stroke signal the involvement of the cerebral cortex, which is the seat of higher order function in the brain. Cortical signs are strong indicators of LVO stroke. FAST-ED's effectiveness at detecting LVO stroke is due in large part to the scale scoring matrix, which gives higher scores to cortical signs. Remember, when signs and symptoms of stroke are detected, make a reasonable effort to obtain and document the patient's last known well date and time, as well as the date and time of stroke sign and symptom discovery. The next step is assessing for and scoring eye deviation. To do this, ask the patient to follow your finger with their eyes, without moving their head, as you move your finger horizontally from side to side in both directions. A score of 0 indicates the patient is able to look to both sides without difficulty. A score of 1 indicates the patient is able to move their eyes horizontally in both directions, but not without clear difficulty. In some cases, the patient may not be able to move their eyes past the midline of their body. A score of 2 indicates the patient's gaze is fixed to one side and does not move. Eye deviation is another cortical sign and a strong indicator of LVO stroke. When eye deviation is due to stroke, the eyes will be deviated or looking towards the side of the stroke. If aphasia was absent, and only if it is absent, check for signs of denial and neglect. Check for denial by showing the patient their weak arm and ask them, "Can you feel weakness in this arm?" A score of 0 indicates yes, the patient recognizes the weakness in their weak arm.
Do you feel weakness in this arm?
Yes.
A score of 1 indicates no, the patient was unable to recognize the weakness in their weak arm.
Ma'am, do you feel weakness in this arm?
No.
Finally, check for neglect by showing the patient their weak arm and ask them, "Whose arm is this?" A score of 0 indicates yes, the patient recognizes or identifies with their weak arm.
Whose arm is this?
My arm.
A score of 1 indicates no, the patient does not identify their weak arm.
Ma'am, is this your arm?
No.
Denial and neglect are also cortical signs and another strong indicator of LVO stroke. But again, denial and neglect are only tested when signs and symptoms of aphasia are absent. If any signs and symptoms of aphasia are present, skip the assessment for denial and neglect. Once the assessment steps of FAST-ED are complete, tabulate the final score. A FAST-ED score of 4 or greater indicates a high probability of LVO stroke. Again, the use of a FAST-ED scoring checklist like the one on your screen now may be helpful to conduct the assessment as well as tabulate the total FAST-ED score. It is important to understand that a FAST-ED score of 0 does not mean the patient is not having a stroke. There are signs and symptoms of stroke not scored by FAST-ED due to their typical lack of association with LVOs. For instance, dysarthria is a sign of stroke that is not awarded points by FAST-ED. In addition, not all stroke signs and symptoms are detected by FAST-ED. In some cases, it may be reasonable for EMS providers to perform additional discretionary stroke screening steps that are not included in our standard stroke screen. For instance, visual field deficits and motor ataxia are not detected by FAST-ED, but are signs and symptoms of a stroke affecting the posterior circulation of the brain. Posterior circulation strokes refer to strokes affecting the blood supply to the posterior portion of the brain, including the occipital lobes, cerebellum, and brainstem. In contrast, anterior circulation strokes refer to strokes affecting the blood supply to the anterior portion of the brain, including the majority of both cerebral hemispheres. Posterior circulation strokes are much less common than anterior circulation strokes and are less likely to be detected during a standard stroke screen. Consider performing discretionary stroke screening steps, for example, a visual field test or motor coordination test when the patient is negative for stroke on FAST-ED scale, but presents with an acute neurological complaint that cannot be attributed to another cause. Again, a FAST-ED score of 4 or greater indicates a high probability of LVO stroke. However, it is important to understand any time you have a differential diagnosis of stroke, even with a FAST-ED score of 0, a stroke alert should be provided to the receiving stroke center and rapid emergency transport initiated in accordance with local protocols. But before committing to a field impression of stroke, EMS providers should attempt to establish a differential diagnosis of stroke by attempting to rule out obvious stroke mimics. Stroke mimics are other acute or chronic disorders that cause central nervous system dysfunction, resulting in signs and symptoms that can look like a stroke. Hypoglycemia is a common stroke mimic that is easily ruled out with a blood glucose check. All potential stroke patients should have their blood glucose tested. Hypoglycemia should be checked and treated according to local protocol. Following a seizure, a patient may present with neurological deficits that look like a stroke. When these signs and symptoms are due to a seizure, they usually resolve without treatment and are not a stroke. A seizure immediately preceding symptom onset is important to document in your PCR and communicate to the receiving stroke center. Suspect a seizure mimic when the patient has a history of epilepsy and the onset of stroke signs and symptoms followed the onset of a seizure. However, a stroke can cause a seizure if the patient does not have a history of seizures and signs and symptoms of a stroke coincide with a seizure. A differential diagnosis of stroke should be established. In either case, assure you convey all relevant findings regarding the patient's history and neurological deficits to the receiving stroke center. Head injuries can impair CNS function and mimic a stroke. Whenever a mechanism of injury is associated with stroke signs or symptoms, assure you examine the head for signs of injury. However, strokes are commonly associated with falls. Keep in mind, a stroke can cause a fall, which can lead to a head injury as well. Other disease processes can mimic stroke and be more difficult to rule out in the field. Migraine headaches can be mistaken for stroke. They will typically follow a pattern similar to previous migraines. Cerebral infections can also mimic stroke. Suspect infection in the presence of a fever. Alcohol and drugs that depress the central nervous system can mimic a stroke too. In the presence of stroke signs and symptoms, an odor of alcohol on the patient or the presence of drug paraphernalia on the scene may indicate a possible stroke mimic. CNS tumors can impair brain function and mimic stroke as well. Neurological deficits related to CNS tumors will typically have a gradual onset. Neuropathies, such as Bell's palsy, can also produce signs and symptoms that mimic stroke. Bell's palsy will produce sudden facial paralysis, affecting the entire face on one side. Even psychogenic causes, such as mental or emotional disturbances, can mimic stroke. It should be noted that your stroke assessment would likely reveal inconsistent findings when produced by psychogenic causes. If you're ever unsure as to whether or not the patient's signs and symptoms are due to stroke, err on the side of caution and provide a stroke alert to the receiving hospital. But assure you communicate all relevant findings during your radio report, including information related to possible stroke mimics. Now that you understand how to establish a differential diagnosis of stroke, it's extremely important that you understand what information regarding the patient's stroke is critical to collect and convey to the receiving stroke center. There are 3 key checkpoints for communication between EMS and the receiving stroke center. These consist of your radio report, your face-to-face transfer of patient care at the hospital, and your patient care record. Provide your radio report to the receiving stroke center as soon as possible. Early stroke notification allows adequate time for the stroke team to mobilize and prepare for the stroke patient's arrival. A pre-hospital stroke alert should contain the following key information: a FAST-ED score, a brief description of the patient's neurological deficits identified during the stroke assessment. Be sure to concisely describe the patient's deficits. Use terms that have a clear definition. Avoid ambiguous descriptions of the patient's deficits. For example, when describing the patient's speech impairments, reporting the patient has trouble speaking is very unclear. Instead, use appropriate terms like dysarthria for slurred speech and expressive aphasia when the patient is unable to speak, or name at least 2 of the 3 objects correctly. Also, provide a last known well date and time, as well as the date and time of stroke sign and symptom discovery. Include any blood thinner medication use, as well as the date and time of the patient's last dose, if applicable. Provide a brief description of pertinent negatives for stroke mimics and other relevant findings or history. For example, reporting the patient was negative for a seizure at stroke onset. If a fall was associated with the onset of stroke, briefly describe the fall and the presence or absence of signs of injury. Provide a list of vital signs, including a 3-lead EKG rhythm interpretation if available. List the care you have provided, and finally, provide an ETA to the receiving hospital. Relevant staff members at your local stroke centers should receive training on FAST-ED in order to interpret the reports provided by EMS during their stroke alerts. The next EMS stroke communication checkpoint is the face-to-face transfer of patient care. Your face-to-face transfer of care at the hospital should essentially consist of a reiteration of your pre-hospital radio report, but with greater detail and clarification related to the patient's signs and symptoms, relevant history, and onset. In addition, it should include contact information for the patient's healthcare proxy, or if a healthcare proxy is not designated, contact information for the patient's next of kin, including the contact's name, cell phone number, and the relationship to the patient when available. This contact serves as a vital source of information for the stroke team as they consider treatment options and look to obtain consent for treatment when the patient is unable or unfit to do so on their own. The third and final checkpoint is the patient care record, or PCR, which offers crucial insight to the stroke team regarding the circumstances surrounding the stroke and the pre-hospital care delivered. A detailed EMS PCR provides critical information that allows for the most expedient stroke treatment once the patient arrives at the stroke center. Your PCR should contain a detailed account of the patient's signs and symptoms, relevant history, and stroke onset. Again, in addition to the standard information documented in every PCR, the following information is critical to include for stroke patients: the FAST-ED score and concise details related to the patient's stroke deficits, the patient's last known well date and time, as well as the date and time of stroke sign and symptom discovery, blood thinner medication use, and the drug's name, as well as the date and time of the patient's last dose when applicable, relevant patient history, including if the patient has a previous history of stroke, as well as a description of any disabilities the patient may have from a previous stroke. And finally, the patient's healthcare proxy, or next of kin information. Limiting time on scene for stroke patients is critically important. Initiating rapid transport for the stroke patient to the closest, most appropriate stroke center is a top priority for EMS. Optimal time management relies on the execution of a streamlined process, which includes the scene size-up, patient assessment, packaging, treatment, and early hospital notification. Even more important is clearly identifying what should be done on scene and what should be done en route to the hospital. The neurological cost associated with even small delays in any one of these steps is too great to ignore. All patients with a new onset of stroke signs and symptoms less than or equal to 24 hours should be treated as priority 1 patients. Keep on-scene time to a minimum, but assure a complete sample history is collected prior to departing the scene. In some cases, a healthcare proxy may be designated to make decisions on the patient's behalf. If so, obtaining their contact information is extremely important. In other cases, a family member or a reliable patient historian may be all that is available. In any case, strongly encourage them to join the transporting crew in the ambulance to the hospital. If they are unavailable or prefer to take their personal vehicle, obtain their name and contact information for the hospital. Patient treatment on scene should be limited to addressing immediate life threats to airway, breathing, and circulation. In the absence of immediate life threats, the most vital pre-hospital treatment for stroke patients is rapid transport. In addition, AHA-ASA recommendations for stroke treatment include limiting supplemental oxygen to the minimum concentration necessary to maintain a saturation of 94% or greater. High concentrations of O2 have been shown to reduce cerebral blood flow, as well as produce oxygen-free radicals that can further damage injured brain tissue. If available, obtain a 3-lead EKG for initial rhythm interpretation. If your assessment reveals a high probability of LVO stroke, lay the patient supine and support collateral blood flow to the ischemic area of the brain. Collateral blood flow refers to the network of cerebral arteries that are interconnected within the brain. These arteries provide an alternate pathway for blood to flow to an ischemic region of the brain when that region's primary artery is blocked. Supporting collateral blood flow during an LVO stroke may help to prevent or delay the ischemic territory in the brain from converting to infarcted tissue. Do not delay transport to obtain IV access or a 12-lead EKG. Both should be obtained en route to the hospital if available. When obtaining IV access, an 18-gauge catheter in an antecubital vein is preferred. When a stroke is suspected, a 12-lead EKG should be obtained in order to rule out myocardial infarction. MIs are not uncommon in the presence of ischemic stroke. A pre-hospital 12-lead EKG should ideally be obtained en route to the hospital. For patients with a differential diagnosis of stroke, do not delay transport to obtain a 12-lead. If you are unable to obtain a 12-lead prior to arrival at the receiving stroke center, the ED staff will obtain one shortly after patient arrival.
There's no question that mechanical thrombectomy dramatically improves outcomes for a select group of LVO stroke patients. Its proven effectiveness is a game changer for stroke care. To support early identification of LVO stroke and potentially decrease the time to mechanical thrombectomy for qualified patients, states and regions around the world are working to identify the most appropriate severity-based scales for their EMS systems. FAST-ED is a promising scale due to its familiar components, a well-designed scoring matrix, which assigns greater point values to the neurological deficits that are highly selective for LVO strokes. By increasing our understanding of stroke, EMS has an opportunity to improve our screening of stroke patients, reliably predict LVO strokes in the field, and better manage our time on scene, and improve our documentation and communication with those receiving stroke centers. All these components are vitally important to stroke patient care. This concludes American CME's presentation on identifying large vessel occlusion strokes with FAST-ED. Thank you so much for watching, and have a great day.
This concludes Part 1 of the Stroke Update training modules. The next module will review in detail changes to the Vermont EMS pre-hospital stroke protocol and how to integrate the use of FAST-ED.